Dean, what are some of the trials that are now looking at immune therapy, and what are some of the new studies that have been published in that area?
Well, yeah, we're now seeing an explosion of checkpoint blockade inhibition. So we're right up there now in terms of what's being done in melanoma and non-small cell lung cancer. Probably the lead study that's been published so far by Tom Poles and colleagues is NPDL-3288. It's an anti-PD-L1 antibody, and it was designed as an extension study. It was multiple arms of the study looking at different diseases. But then when it was observed that bladder cancer responded quite nicely, it was extended, and that study has been reported both at ASCO and at ESMO, and now published by Tom and colleagues. Bottom line is this, and that is that it's a highly active drug. The observation has been, is it related to the PD-L1 expression in the tumor? The studies are very interesting. If you take a look at the patients who are high expressors, in general that's 5% or greater or 10% or greater, those are the high expressors of PD-L1, that collective response rate in that group was 52%. In contrast, in the patients who were 0 or lower expressors, and it was 1% of cells, that was 11%. So it really does look like that the activity of the drug follows the biology of the development of the drug. That being said, even in the lower expressors, that's a pretty high number compared to what Evan, you were just talking a few minutes ago about what we have available to us, and there isn't a standard of care. So that's highly encouraging. In addition to that, I think what's important, what we've been talking about, is they generally are patients who are frail, who have multiple comorbidities, and if you really look at the toxicity profile, it's extremely well tolerated in terms of treatment. And that is, we look at grade 3 or 4 toxicities. We usually in studies we're looking at, 15, 20% grade 3 or 4s, and here it's a 4% toxicity, or 4% incidence of grade 3 toxicities or more, no grade 5s. And most of what we're seeing are fatigue and rash, et cetera, but not major toxicities, not like we've seen with chemotherapies beforehand. So that's encouraging. But then if you look at the presentation that Joachim Belmont made at ESMO, I think what took all of us probably a little bit by surprise, but was very encouraging, is the swimmer plots. Is that when you see a response, these responses, at least at first blush, seem to be quite durable. And that's very encouraging because we talked earlier that the median progression-free survival in some of our older studies is 2.5 months, and yet we're seeing swimmer plots where they're going out, quite lengthy responses. So
I think we're also seeing some stable disease too, which we don't see much of with standard chemotherapies. You either respond or you don't, but with the swimmer plots, you can start to see stable disease as well.
Right, and it's actually helping us redefine benefit, because if you take a look at the chemotherapy studies, when we define benefit, we're talking about shrinkage of drug, and we really don't have good studies in terms of quality of life and tolerance, et cetera. Now what we're seeing is benefit may not necessarily be reduction of disease, it's lack of progression of disease, like we've seen in renal cell carcinoma, but also intolerance of therapy, which is really important for these patients.
And patients can be treated with this on a long-term basis. We've had 3 complete responses, and 1 now is closing in on 2 years of treatment at this particular point. They do generally very, very well with it. It's unlike what we've seen with some of the other CTLA-4 antibodies, where you do develop hypophysitis and you develop GI complaints, colitis and LFT abnormalities. It's a much, much better tolerated drug. And I think that your point about the second-line negative patients with the 11% response rate, because the responses are generally so rapid, you can effectively evaluate somebody earlier and then move on to something different with certainty that they may not respond if they're progressing at that particular point. So the median time to response was somewhere around 42 days in those responding patients. But I think that the whole issue about trying to figure out who's going to respond and who's not going to respond, I think, is really a crucial one. The immune cells are the ones that seem to be the gatekeepers here. It's not necessarily the tumor cells, and that's one of the problems with comparing this to the pembrolizumab trial where they actually looked at the tumor cells and selected patients based on that. The Genentech trial went through a variety of different iterations because first we treated only positive patients, and then we went on to add negative patients in, and then we went back and forth on this whole issue. So I think it's something that really does need to be sorted out.
Well, I'll add one thing, is the point you mentioned earlier is who's really positive and who's really negative. I mean, if you look at a lot of these trials, a lot of these tissues were obtained from transurethral resections, from cystectomies that were months, maybe years ago. And so the tumor evolves over time. And so, and you know, PD-L1 expression can certainly be affected based on exposures. We think there's possible things, smoking, BCG, prior chemotherapy. The expression patterns may change over time. And so again, real live tissue, especially tissue from a metastasis, we don't have that. So some of these findings, biomarker correlating to response, that might not be perfect, might be because we don't have real-time assays.
Well, this may be one of the reasons why bladder is so unique with its response rate and very similar to lung cancer. As Dean pointed out, many mutations in bladder cancer. It seems that the tumors that have a high mutational rate are the ones that are going to respond to immune therapy, melanoma, lung cancer as well. You know, as some of these studies mature, as in lung cancer where we've seen there's a correlation between smoking and response to the anti-PD-L1s. In fact, my chairman, Roy Herbst, who's done a lot of the lung cancer work, has said, "Now this is not an excuse to go back smoking again, that you're going to respond to treatment." But I think again, this is why it's a very, very complex system. The specimens that were taken for the MPDL 3288 trial were taken from archival tissue, and we did rebiopsy some patients, trying to get them on the study if they were negative to begin with. But that also needs to be examined. What's the role of chemotherapy? The induction of inflammation that can go on after that, does that have an effect on the immune cells? The sequencing is going to be an important issue, because if by giving chemotherapy, do you augment the immune response? Do you actually blunt it? So these are all issues that are going to come into play over time.
Well, I think you both make really excellent points. When we look at you know, genetics, for example, sequencing, we're looking at one part of the tumor and then maybe another part of the tumor. But now we're talking about an immune system, which is a dynamic system at any one time. So, Evan, you were talking about, you know, what was taken in terms of biopsy. It was anything we can get our hands on.
That's right.
And we're trying to do correlations on that. And in point of fact, actually, we're really not looking at the patient as a dynamic system in which you've got an active immune system. And Dan, you make the point, yes, we're looking at tumors which have a high degree of a high mutation rate, you know, like melanoma and non-small cell lung cancer. And then the New England Journal article by Alex Snyder just a little while ago, dissecting out the melanoma patients, and the ones with the highest number of mutations, again, were better responders, durable responders than the ones with the lower ones. And now we're now targeting down and looking at actual antigens, and neoantigens that might be, you know, the antigen of interest, kind of like we were talking about HER2 before with with the other trial. This is an area we're going to be investigating with incredible intensity, you know, and it may not be simply immunohistochemical staining pretty soon. We might be looking at a genetic signature or an RNA signature. You know, it might be smokers, non-smokers, might be a smoking signature, for example. We really do need to drill down and identify more information.
And so Joe Kim from our group is presenting some data at ASCO GU this year looking at myeloid precursors and its effect on response to the anti-PD-L1 antibody. And you know, he's showing some interesting correlations with that. So it's not only the PD-L1, because of course it may be the tissue issue about the sampling with those 11%, but it also may be that there are alternative pathways of resistance that are activated. So this is an extremely complex system. I don't think it's going to be just one marker that's going to tell us what to do. As you said, it's going to be a panel that helps us understand this.
And the panels may be tumor-derived, and it might be the host. Now we're talking about the host system as well, and so, you know, and those are, you know, both working in concert. You brought up the issue of BCG. Are we sensitizing these patients to, and now we're getting neoantigens, and we have not yet looked as to whether responses are related to prior therapy. We're talking about cisplatin earlier, and maybe we're increasing the number of mutations or alterations and therefore a number of neoantigens, and maybe that might be beneficial for all we know in terms of prior therapy. These are things that are really important to examine.
So Genentech